Hello, my name is Dr. Jacqueline Saw. I'm an interventional cardiologist at Vancouver General Hospital. It's my pleasure to show you two cases today of device embolization that we were successful in retrieving percutaneously. Both these embolized devices were ACP device, and we utilized the gooseneck snare technique to retrieve both these devices successfully. So the first case example is a patient with a windsock-like appendage. The landing zone measured approximately 20 millimeters in this case, and we used a 24 millimeter ACP device. The procedure itself was quite straightforward. As you can see, the device had met the 5 signs for the ACP before release. Overnight, the patient became quite agitated and combative and delirious, and the following day when we did the echocardiogram, we found the device to have embolized into the left atrium. So we brought the patient back to the cath lab, and we accessed the left atrium via the same transeptal puncture from the day before. We put a 16 French sheath, check flow sheath into the left atrium via the right femoral venous puncture, and we placed a 20 millimeter gooseneck snare inside a 5 French EBU guide, and used the EBU guide to help directionalize the snare to capture the device. As you can see, the device is quite freely floating around in the left atrium, and our goal here is to capture one of the end screws, which took a little bit of time, but we were able to ultimately actually contact and grab hold of the end screw right here. And when we connected to the end screw, we pulled the EBU back into the sheath. And the key here is to really try and achieve a coaxial placement. And unfortunately, in the first attempt, it wasn't coaxial and the device had come loose. So we had to repeat the same process again. And on the second attempt, we grabbed hold of the end screw very tightly and was able to get a coaxial position. And once we achieved this, we had to hold the EBU against the gooseneck snare very tightly, and was able to then pull the whole system back into the 16 French guide. So this is case number 1. The second case was more challenging. This is a chicken wing anatomy with a sharp band quite proximally. The landing zone we measured 24.9. So we implanted a 28 millimeter ACP device, and the procedure itself was not particularly difficult, with the exception that we actually had to access this patient through the left femoral vein because the right femoral vein was occluded. So once we achieved the 5 signs of the device implant, we released the device, and unfortunately the next day on an echocardiogram, we found the device actually to be free inside the left ventricle. And in fact, the echocardiogram showed the device to be at the LVOT. Now, the patient was asymptomatic at this point, but nevertheless, we rushed to retrieve this device quite promptly. So we brought the patient back to the cath lab, gained femoral arterial access with a 14 French sheath with 2 proglides to pre-close. This is a 80 centimeter 14 French sheath, which was the largest and longest sheath that we had available at that time in our lab. We advanced that through a stiff implant wire into the ascending aorta. And through this 14 French sheath, we advanced the JR4 guide into the left ventricle across the aortic valve, and used a 10 millimeter gooseneck snare with the intention of grabbing hold of one of the end screw, preferably the distal end screw. And I would have thought that if we were to pull this up, the hooks of the device would point away from the aortic valve. And as we were pulling it up against the aortic valve, the patient actually went into 3rd-degree AV block. And so we repeated this same process, but this time place a transvenous pacer and pace the patient at 70 beats per minute. And we did the same step where we used the gooseneck snare to grab hold of the end screw and then again pull it up against the aortic valve. And this time we managed to pull it across the aortic valve into the ascending aorta and down to the descending aorta. And as we were trying to pull it into the 14 French sheath at that time, the gooseneck snare had come off the end screw itself. So we had to now switch gears to using a bioptome inside this 14 French sheath and try and grab and pull the end screw and the rest of the device into the sheath. As you can see, this is not that easy. We had to use multiple tries, and we also finally had to grab the end screw very, very tightly with a bioptome and very slowly exert a lot of firm force and pull this device into completely inside this 14 French sheath. As you can see, this is achievable and complex. And there was no issue with the aortic valve. The patient was very stable beyond the 3rd-degree AV block. Now, in terms of snaring a Watchman device, this is a homemade video just to show you the same technique of using gooseneck snare inside a guide. You can use a large sheath, like an 18 French sheath, to pull a Watchman device inside the sheath of the gooseneck snare. Alternatively, other clinicians have used alligator biopsy forceps to pull Watchman devices in. This is a case example from China where they utilize alligator biopsy forceps and grab the device hub of a 33 millimeter Watchman device and pull it inside a 12 French sheath. So this is possible. Now, the absolute equipment required in your cath lab to retrieve devices are as follows. You need a large sheath, preferably somewhere in the range of 14 to 18 French. The larger, usually the better. And gooseneck snares, I find, are more useful than end snare. And if you don't have these snares available, vascular forceps can be useful. And I've shown you an example where bioptome can be useful as well. So these equipment is absolutely required if you were to be implanting atrial appendage closure devices. Thank you for your attention.